Hi all, this is your Dr. House of Pelvis, and this video we'll be discussing on going through fetal physiology and what is the positive energy balance, how baby responds to the stress in normal physiological conditions, and how does placentation affect the oxygenation of the baby, and what are the peculiar features of fetal hemoglobin that actually helps in maintaining the fetal physiology and the fetal heart rate, and how does fetus responds to hypoxic stress? What is the pattern in which the baby is supposed to go through when the baby is exposed to a stress? Okay, now let us imagine ourselves going through some stress. Somebody tells me that, yes, Dr. Bala, you need to go for a 100-meter race. I'm going on the track, I'm standing, and I'm thinking, I have to run a 100-meter race. How prepare myself first? Yes, I slightly warm up myself. 1 second. I hyperventilate. I'll take long deep breaths. What does hyperventilation do? The hyperventilation causes washing out of carbon dioxide, thereby replacing how much ever carbon dioxide there is inside by oxygen. So, and we use the same principle in pre-anesthesia also. Before general anesthesia, we do pre-oxygenation, by which we replace the functional residual capacity with oxygen, thereby you get time for intubation. So this is the oxygen reserve that you are creating. I know for the 100-meter race which I am going to run, I cannot breathe properly. So I need so much oxygen to be utilized in the body. So I do a presumptive reservation for oxygenation by causing hyperventilation. 1. Second thing, as soon as I start to run the 100-meter race or I do my warm up, the thing that happens is my heart rate increases. Now, in a normal adult, when there is a stress, the sympathetic nervous system is activated, because of which the heart rate will increase. But when heart rate increases, the oxygen consumption will also increase, and this increased oxygen consumption, which is required because this heart rate increase will increase the blood flow to the periphery, and this blood to the periphery should be rich in oxygen, and this rich in oxygen is compensated by increasing the respiratory rate. So as an adult, when the heart rate increases, to manage the stress, your respiratory rate should increase along with the increase in heart rate. So that's how we manage stress. But in babies, we know there is no respiration. There is no respiration in a baby. So when there is a stress that is given to a baby, if, God forbid, it had to increase its heart rate for this stress, and there is no way the respiratory rate can increase, there is no way the oxygen input can increase. There is no way the oxygen input can increase. The blood to the periphery increases, but there will be lack of oxygen to it. And this is a problem. I cannot allow this thing to happen. Yes, it is not happening. So that's how, to maintain a positive energy balance in the baby, with the amount of energy that is reserved. So I already discussed in the previous video, the stress is nothing but uterine contraction or anything that causes fetal hypoxia rather. Anything that causes fetal hypoxia is the stress. So anything that causes fetal hypoxia, the problem is not having oxygen. And by mistake, if I increase my heart rate, I can never ever protect my vital organs. So that's how baby, in case of stress, the baby's physiology is adapted in such a way that whenever there is a stress in fetus, the heart rate of the fetus starts to decrease. Thereby, it decreases the oxygen consumption. So this is the first thing that tries to happen. There will be a small decrease in heart rate and sees if the oxygen can be revived back within this particular period of time. So if the stress is given, the baby's heart rate decreases, thereby decreasing the oxygen consumption, and if the stress is removed, the heart rate gets back to normal and the oxygen consumption returns back to normal. But now, if the stress persists, is what we are going to learn. This is it normally happens. There are Braxton Hicks contractions that always happen in the third trimester. Even that can cause stress. So that is normal. So if this stress persists, how the baby is going to respond to it is what we are going to learn by understanding how placentation is affecting and how fetal hemoglobin is affecting the maintenance of normal baseline heart rate and maintenance of normal fetal functions which the baby is doing. Let us remember for once the hierarchy of saving organs. Okay, so please remember this throughout the discussion. In the next 10 to 12 videos that we'll be discussing the cardiotocography, this will be the hierarchy in which the organs needs to be saved. The first thing is the baby should be alive. So baby should be alive. So the first thing, that the only organ that needs to be protected is the heart. Okay, if the heart is having enough oxygen, good enough, then I'll try to give a baby which has senses, not just living in coma, but I want a baby who actually works and who thinks. So if my heart is saved, then I'll try to save my brain. Once my brain is saved, yes, I'm having enough blood for heart, I'm having enough blood for brain, that's when I try to save my kidney. Right? You will understand why am I plotting in this order. Fourth thing, once I'm having enough oxygen for my heart, I'm having enough oxygen for my brain, I'm having enough oxygen for my kidney so that I can pass urine, it's then when I will be like, okay, I can plan for a jogging in the morning, I can go for a gym session today. So then comes body movements. Because I don't want to move my body when I'm not having oxygen to my brain. As simple as that. I'll not try to move, I'll try to stay still. And just giving you some basic hints, we will be discussing this in depth in the next video on what is the reason why we have baseline heart rate, what is the reason why we have beat to beat variability. We will be discussing that in the next video. But I'll give a link because this is the dictum that we will be following. So heart is having a positive energy balance, and the normal stress is directly taken care by the heart by decreasing the heart rate, as simple. And the brain is required to, basically the brain, we mean the autonomic nervous system of the brain. If it is intact, then for small stress that happens in the body, there will be a slight up and down regulation of the heart rate. There are small stress that happens biochemically throughout the baby's body. So these small stresses are being handled by every beat. There is a small biochemical change that happen in the body. So for those stress, if the brain is good, so it tries to maintain the heart rate by slightly changing its heart every beat to beat. So the brain's intactness will maintain the beat to beat variability. Beat to beat variability. See, I have not discussed about these concepts yet. We will be discussing in the next video, but I am just giving what will happen in this scenario. Now, if the kidney is functioning well, then it will form urine. So you will have adequate liquor. Then body movements. So if the baby is having enough oxygen to maintain the heart, brain, kidney, then it will start moving. So the mother appreciates adequate fetal movements, which is calculated by Cardiff's rule, right? So whenever the mother complains that the baby is not moving well, why are we afraid? Why are we doing a non-stress test? I think you are getting a glimpse, right? Because the baby is entering into the first phase of hypoxia and it might land up with having a stillbirth if the heart stops. Understand? That's why we take a small complaint that the baby is not moving in the third trimester, we take it so seriously. We try to evaluate after 32 weeks. We try to do a CTG. We try to NST. We try to get a USG Doppler. We try to rule out all the causes of why the baby is not moving. It could be just sleeping, yes, but let us prove it. Let us prove it all otherwise, that the baby is completely fine otherwise, and then we send the patient home. Yes, you're getting the concept of NST right now. Great. Now, we will discuss regarding the concept of placentation. So, around 12 days, the placenta formation starts to begin. I mean to say, it's not just the placenta, it's the chorionic villi. We know by day 6 it starts to implant in the uterine endometrium, and by this will be the blastula that will be in the endometrial cavity, and this will divide into two cell layers. We'll have the outer cell layer and we'll have the inner cell mass, right? And this is going to come and get implanted here, and when it comes, it is going to have a pole which will be told as this will be the embryonic pole, this will be the ab-embryonic pole, right? And this starts to invade into the endometrium, right? So when it starts to invade the endometrium, here we have the chorionic villi which starts invading into the endometrium, and when it starts to invade, they try to form something called as endometrial sinuses. These are the important structures that you need to remember. So when the chorionic villi is invading, there are some spaces that are formed, and this is the, there is a barrier that is there, and here is the spiral artery that comes and pulls down, and these enters into this lacunae, and the spinal arteries bleed into this. This is a maternal blood pool, and the fetal blood is just transferred, exchanges oxygen and nutrients across these lacunae. So if there are adequate number of these are called lacunae. So if there are adequate number of lacunae, this acts as a good reserve for the positive energy balance for the baby. And we know when the lacunae is not formed properly, in which conditions where lacunae does not form properly, there could be a simple villitis, there could be an infarction in the placenta, or there could be an abnormal invasion of the spiral artery into the lacunae, which is classically seen in pre-eclampsia syndromes or hypertensive disorder of pregnancy, where there is trophoblastic invasion is being hampered. So the lacunae formations are very less. Fourth, in patients with diabetes. So what happens in diabetes is slightly more fun to learn. So in diabetes, what happens is there is a process that's called as hyperplacentosis. So what is hyperplacentosis? Simple. In diabetes, everything increases in size because of excessive glucose. So the placental mass, which was normally like this, increases like this, and there is increased vascularity, and because of which the effective space for formation of lacuna is very less. So the number of lacuna is reduced. So because of more mass of placenta, which is formed by VEGF and all, we know even in retinopathy we have learned, right, proliferative diabetes and non-proliferative. So if it is landing up in proliferative placentopathy, right, there is something called as obstructive vasculopathy. Similarly, we have proliferative vasculopathy of the placenta that is set up by diabetes. The increased vasculature itself compresses the lacunae and decreases the reserve that we have. So that's why diabetic patients, babies of diabetic mother, even with small stress, undergoes sudden stillbirth. Getting the concepts how placenta is so vital. It's a black box of human body, I would always say. This is a black box, and we need to start doing more research on placenta. And you can see one of my research in placenta, and I'll try to link it in the bio below so that you can see how placenta is actually affecting the baby. So now you are understanding in placentation, the most important factor is presence of lacunae, and how, in which all factors the lacunae were affected. Then we will go into a process. Okay, now the placentation is completing. The placenta's reserve is one of the factors that we will keep in mind, and this is ultrasonographically also can be predicted based on the grade of placentation. You know, the calcification, the amount of calcification in the placenta can be seen by, we'll tell as grade 0 to grade 3, based upon the degree of calcification. And the more the calcification the placenta has, the less space for lacunae. So that's why grade 3 placenta is an hypermature placenta. In a hypermature placenta, we are always careful that the placenta is completely mature. Now, either if the grade 3 happens in quite early pregnancy, like 30 weeks or 32 weeks, then we are like, the patient will end up in a preterm labor. We are having a prediction that yes, why is it calcified so much? Or either the patient will have a preeclampsia syndrome. So that's when I think we need to start analyzing placenta of every delivery and just not throw the placenta away. And there are a lot of uses of placenta, and our understanding will further increase. Going ahead, we will be discussing regarding what is HbF and how does it affect the normal oxygenation of the baby in the upcoming video. We'll keep all these videos short so that it'll be easy for you guys to revise once and when you go as a part of revision. And yes guys, so we have discussed two small parts. One is how baby starts to respond, what is the chronology or the hierarchy of prevention of hypoxia in the baby's vital body functions, and then how placentation affects the same. So in the next video, we'll be discussing the next two parts of the fetal physiology. One is how fetal hemoglobin affects the oxygenation of the tissues of the baby, and how it affects the fetal heart rate, and how fetal hypoxic response actually happens. So as always, keep learning and keep teaching. With love, Dr. House of Pelvis.